Are coming back up for our last session of open discussion. Leave the microphone here. All right, got John in. So I want to thank everyone. Everyone stayed on time except for Brian. You ran over, but we won't hold that against you. So maybe you'll get the first question. Stu, please.
Okay, thanks. Great session, thank you. Just a quick question first for the surgeons as to what exactly you mean by a slip fundoplication and how you recognize it, because I've heard different descriptions from different people.
That's a great question.
Start that. I think a slip fundoplication that is on the proximal stomach rather than being on the esophagus. On endoscopy, antegrade view, you'll see the GE junction and then the gastric folds and then the fundoplication. That's what I would consider the slip.
So the fundoplication is below the G junction?
Is on the stomach.
Yeah.
That's
Okay.
what, is that?
Everybody agree?
Yep.
Okay.
I think that term gets misused a lot, Stu. I think you're absolutely right. Because people refer to a wrap in the chest as a slip fundoplication. People refer to, so actually John had a great diagram up when he was talking. It just flipped by, but there's some really good diagrams that describe the distinctions that we
We
talked
would
about.
call the one that's gone into the chest as an intrathoracic fundoplication, if it's still around the right place.
Or a herniated fundoplication?
Herniated
Yes.
Herniated, migrated.
Okay, and then with that out of the way, so one other question. So we've seen these cases, patients who generally have not had a pre-op motility study, but post-op looks like achalasia, right? But now you have a patient who's had a fundoplication, so it can be difficult to make that diagnosis, right? They have terrible motility, they have high IRP, but is that due to the fundoplication? So let me ask John, first of all, does it make any difference to you? And do you think endoflip is helpful in that situation? Or are you just going to dilate that anyway?
Yeah, I think endoflip can help you a little bit there. I think some of the provocative testing too is actually somewhat helpful. You know, we used to have amyl nitrite. We used to do that all the time. And that was a really nice tool, but now it's not available. And now there's a little bit more interest in doing CCK. So if you give the patient CCK, you should see that paradoxical response. You know, I think it's a lot of judgment. You know, do they look like they're dilated? You know, that's why we just have to do these motility studies ahead of time.
Yeah,
It is confusing.
I agree. Yeah, but for the surgeons then, and if the situation that you can't figure out whether it really was achalasia, and
You know, usually that's why I say that you need to talk to your patient yourself and not because somebody sends them. You know, they may have those bland regurgitation that, you know, was missed in the pre-op. If you see a barium swallow, you know, even though they may not have dictated achalasia, if you see some of the pictures and you start seeing a column, maybe. And two, I think then it's an intraoperative assessment. When I take the wrap down, I may try to see if it opens up, and I think in going future, maybe do an endoflip in the operating room after the wrap is down and see what we do.
will you do a, this keeps falling, will you do a myotomy with a fundoplication?
If I'm convinced it was achalasia or a missed achalasia, yes.
So, while Phil's coming up, though, I want to just actually elaborate on Stu's question, because the issue of complete workup, I mean, it's come up, you've all mentioned it, we all live with this, but there are a lot of instances in the community where a complete workup isn't done. And in fact, on some of the social media sites, even amongst surgeons who do foregut surgery, this question is ironically still being brought up. So are there scenarios where you would accept an incomplete workup? And if so, which one would they be? So if someone's got LA grade C esophagitis, do you need a pH study? No. If someone's got clear evidence of a normal barium swallow, do you still need a manometry?
I
do.
don't.
I do.
You don't?
Not necessarily.
You do?
I do.
You do? You?
Yeah, I get one. Just because
I get them every time. I won't do it without.
That Stu just gave us, which is you're sitting there with no information.
Right.
Again, what is a normal barium swallow? It's the one that I've been able to see myself as a video esophagram. There's a big difference between a normal reported barium esophagram from outside with static pictures versus a video esophagram that I can get in my hospital and look at it myself. There's a big difference between the two. That would be my disclaimer.
What's that?
Yeah.
Yeah, but that comes from USC. That kind of is what it is. So Brian, real quickly, you know, when you take a PPI once a day, you normalize your esophageal pH about 70% of the time. Now, you can't directly correlate that with symptoms, but if you look at the old esomeprazole database, complete symptom relief, which meant 7 consecutive days of heartburn, was about 65 to 68%. So the link state is not too far off from that. Now, why you'd have an abnormal study and still have symptoms, I can't really tell you, but the need for complete normalization to get symptom relief doesn't always exist. So it just may not be that aberrant.
Yeah, you know, I think what you raise is a good point. And the question is with the Lynx device, did we reduce just that amount of acid flow, just enough to sort of put that patient in a position that's a better sweet spot for them, and they just don't have any sensation?
I think that's probably the case. Quick question for all of you guys about dilatation. I usually use a tablet when I do a barium swallow as well, just to see if I can find a stopping point. It's apparent that a 30 millimeter balloon is safer than the general public thinks. So if you guys can make some general comments on that for the audience. And why in the world do you use a 35? That I'll ask you separately. But Katska, does anybody ever have a proven vagal problem after a fundoplication, or is it all supposition? Because that elegant talk seemed like there was a lot of supposition, but not anything that you could count on.
I think they do, but I think it's overestimated.
Okay.
And I think at least part of the strategy is you've got to work up all the other reasons for vomiting, nausea, postprandially before you start messing around with the pylorus. And there are a lot of other reasons that, whether it's gastroaccommodation, gas flow with bacterial overgrowth, all these things, I think, before you automatically blame the vagus. As far as dilation, we've published on post-fundoplication dysphagia. We use a pneumatic, we get a 50% response. I think the other reason using pneumatic is what Stu said, is that if you get these rare cases where you're not sure, you're kind of treating both with a pneumatic as well.
No, I understand, and I'm comfortable with that, but there are two parts to it. It's hard to think about dilating everybody, whether they need it or not. So there should be some criteria for when you do.
Absolutely.
And for people who don't do this very often, not necessarily would I want them to go out and start using a 30, but the fact is it's really quite safe.
Yeah.
And that's, another reason why we shouldn't abandon that in a lot of ways. But I think people should know that that's a safe intervention after a fundo.
I think so. We haven't had any perforations so far. Not that we've done hundreds, but our experience has been good. John?
Yeah, we've had 3 perforations in the last 15 years, and I'm pretty sure that 2 of them were not even truly a full-blown pneumatic dilation, just complicated surgical. 35, also I think is very safe. If I don't get a response with a 30, I'll do 35. If you look at Ian Cook's paper, where he talks about this, he does 35-40, and I know there are a lot of people. I think if the 35 doesn't work, I think then the risk of the 40 becomes a little bit too much for me, that I would say, all right, let's just get this taken care of in an operation.
Microphone 1.
I have to go find my achalasia balloon. Our hospital, I don't know where it is, so.
Hi, Kristen Beard from Round Rock, Texas. I have a question about patients who are having problems after they've already had a callus gastroplasty. So for those patients who are still having GERD or esophagitis that's hard to control with medical therapy, and they want us to do something else, is there anything else that can be offered, like a stretta? And if so, is that safe, and where do you put it in the neoesophagus? And then is there a strategy to deal with patients after a callus when they have a recurrent hernia despite the lengthening procedure?
Well, I think the first thing is after a callus, medical management, maximal, to see what's going on and see if you can get it controlled. I definitely think you need a gastric emptying study because you don't know what you've done necessarily there. I personally have not had one where we've had it that bad, but I think if you can't get it healed with twice daily PPIs and some nighttime Zantac, and if your gastric emptying is normal, then I think you're stuck for the long haul and looking at perhaps doing a bypass and probably an EJ, because that callus segment is is going to screw up any kind of Roux-Y you're going to do, or gastric bypass.
Totally agree.
Yeah.
Totally agree.
Yeah, I think at that point, I would say if you've exhausted everything else, I think a Roux-Y bypass is probably your best option. I have no experience with trying to do stretta after callus. I don't know, Lena, you're out there now. Any of you guys strata post-callus? I've no experience with that at all.
Ken Chang's nodding no down on the front.
No,
so
Ken is
Ken's nodding
heavily
no. I don't know
shaking
anybody
his
who
head
might-
no. That's a hard no. Vic?
Yeah, it's a great session. We published previously on the importance of identifying those patients who have some kind of psychological or chronic pain syndromes prior to surgery, because they're going to be dissatisfied afterwards, even if they have no reflux, they complain about their trocar sites hurting, or they have some other kind of nocebo phenomenon going on. And I know that I saw that Dr. Panafilo touched on that a little bit, and so did Sumit. How do you handle those type of patients? Because really they should have never gotten an operation to begin with. It was almost predictable that they're not going to be happy. And then number two, what about the functional disorders? I think we underestimate the number of functional disorders, functional heartburn, functional chest pain, et cetera. And people come in with an operation, again, that they should have never had because it was a functional problem.
So while you guys are thinking about the answer to that question, it just brings to mind an old adage that I was taught, that you can't fix a supratentorial problem with a subhiatal operation. We fall into this trap more often than we'd like to believe because we get conned by our patients.
That is why you don't operate till you're convinced you're
Right.
going to help the patient, either the first, the second, or the third time.
I think that's a great question, and it, we've been working on trying to get a better assessment tool to see who are the people who are going to get better and who are not going to get better. And Tiffany Taft, one of our psychologists, worked with our team, one of our fellows, and we've developed something called the EHAS. We just published this paper. It's the Esophageal Hypervigilance and Anxiety Scale. And it's interesting because we first tested this in achalasia patients who had a good response based on bolus retention and physiology. And we could see that there were two groups. One group that their Eckert score was very high, and one group Eckert score is very low, despite the fact that their bolus retention and their physiology looked the same. And the thing that actually predicted the difference was the EHAS score. We have another multi-center study where we're looking at motility, and the thing that predicts their symptom severity is the EHAS score. So I do think that this is something that should be assessed in all patients before they get an operation, because you actually do have an opportunity to intervene, because you could actually get that patient kind of dialed back, their expectations dialed back, you can get their cognitive flexibility dealt with, and then at that point, they'll be better off. And in fact, we have a study that it's probably going to start in a year that's going to look at that ability to preemptively address those factors before they get their surgery to see if we improve outcomes. So it's a very important thing that we have to address.
Well, I tell you, I think there's even an easier one when they come in and they have a medical allergy list that's 20 drugs long.
I like when the blood pressure cuff hurts.
Yeah,
That's usually how.
so those are usually pretty good signs.
Yeah.
So unlike John, we don't have as readily access to psychology, and it's something that we're working on as a GI and surgical group to sort of acquire one. But in the absence of that, what I've actually found helpful with some of those patients, because my partner Ralph A has a screening tool that we've tried to use, and it does pick out people fairly well. But we actually have two naturopaths that have a GI interest, and they work closely with the Cancer Institute that is at our site. And we've talked to them about what do they have available to us. And so we send a lot of those folks away from us for a while. But when they come back, the naturopaths have actually done a fairly good job of helping those guys out. And so we've used them instead.
I think there are 3 steps for these patients. I think the first is, like any functional patient, you've got to take their symptoms seriously. When we say it's in your head, you've lost them already. Number 2, I think you have to prove the sensory-motor mismatch. So we will do tests, whether it's pH monitoring. We now do solid phase esophageal emptying on these patients who have functional dysphagia and show them that their symptoms are occurring but don't match the physiologic studies. And I think the third is, as John said, you need intensive therapy for their sensory dysfunction. Whether it's central, peripheral, or both, I think you have to offer them therapy. And a lot of the therapies, be it low-dose imipramine, duloxetine, meditation, all these things can be very helpful for these patients. And then finally, I'll add a 4th step, is you have to reset their expectations. And I think if you could do those 4 things, you can really help a lot of these people.
and not operate on them.
Well, I think that's the message, Paresh. I think if you, for the surgeons group, if you just say, look, I can't help you with any of those symptoms, some of those folks are actually relieved that they don't need an operation, and they will leave your office, and they'll be happy that you don't need to operate on them.
Hi, Ann DeWitt, the dietitian with Dr. Job's group. So when I think about the dissatisfied patient post-surgically with anti-reflux disease, the change, the exacerbation of functional bowel issues comes to mind. So I wonder if you could address that and maybe the reasons as to why.
It's the question's focused on functional. Yeah, I mean, obviously, whenever you do anything and you affect the stomach and the bowel communicate. You know, the vagus nerve, as Dave elegantly showed us, has a lot of communications. There's a gastrocolic reflex, there's a brake. You know, there's all these interactions that happen. And I think when you take away the ability of the stomach to accommodate the food bolus, you know, you affect that. And there will be people who get a sensation of the postprandial syndrome. There will be people who those gastrocolic reflexes either get destroyed and they'll have more constipation, or they'll actually have diarrhea. So what I wind up doing most of the time is telling them that this is not unexpected. We see this. This is probably why it happens. I explain the physiology, whether they have constipation or diarrhea, and then I treat them as if they just have functional bowel disease. And that's pretty much where I'm at. You know, dietary modifications, maybe some antispasmodics, focus on the symptom, whether it's constipation or diarrhea.
Thank you.
I think a lot of these patients had underlying IBS that
Yes.
got unmasked because at that time the heartburn was taking over all the symptoms, and now that's gone, the other symptoms become more prominent.
Yeah,
They
I
have
mean,
something to complain about.
I mean, studies have shown if you take people with IBS and you wait long enough, they'll develop dyspepsia. And similarly, Joel Richter showed beautifully years ago, if you have someone with a hypersensitive rectum with balloon distension, even if they're asymptomatic, you blow up a balloon in their esophagus, they will be hypersensitive in the esophagus as well. But I think what's also important is something John mentioned, is that you have to understand the relation of all the organs. So one thing Michael Camilleri taught me early on is the best treatment for gastroparesis is to treat the constipation. So sometimes by treating their lower GI symptoms, you will in fact treat their upper symptoms very well too.
Reg?
Yeah, actually, Anthony's over there.
Oh, I didn't see Anthony. Sorry. Go ahead.
Sorry.
Hello, Anthony Starpoli, New York. Any comments about using endoluminal therapy in innocent failure, like TIF?
I don't personally have any experience post-Nissen in doing a TIF. You know, I think I subscribe to Samit's version, which is if the fundos failed and if you're going to go back and you've made that decision, the whole thing's got to be taken down again. So I'm not sure I understand your question. Maybe Samit
Well, for
does?
example, in the case of a loose wrap, not a herniated wrap, not a complication to the wrap, but simply a loosened wrap.
I have no experience in that,
Yeah, I don't either.
or any endorsement on my part at least.
Well, I mean, Anthony, you do TIF, so not to put you on the spot,
Yeah,
but
no.
but have you had experience?
I've done probably about 7 or 8.
Yeah.
Dr. Chang, have
Ken?
you done any?
As long as the crura is still intact, it's not a failure of the hernia,
Right.
and it's the wrap that's loose, yes, very straightforward for us to go back and use TIF to remodel the valve.
And recreate that same
Exactly.
wrap
Correct.
that we
Same
had started
wrap.
with
Correct.
before.
Yeah.
Yeah.
Correct.
And your results so far have been
They've done
promising?
well. They've done
Very
very
good,
well.
yeah.
Have you gone back and actually studied them with pH studies or impedance to see if the acid exposure
In
is
a
reduced?
couple I have, in the majority I have not.
And
But
how long have you had
symptomatically,
follow-up for
they're
those?
PPI free.
How long of follow-up have you had after those?
Oh, they're out a few years.
Okay.
That'd be worthwhile presenting, because I'm not sure
Yeah,
that's something
I think
that's
that would
very
be
well
good.
known. So
That
if
would be
you,
good
you
to-
can
Where do
get
you
your series
practice?
together,
Present here.
you should present that.
Yeah, no,
We'll get together, we'll
really,
do it.
You should.
Oh, we'll send you. I don't
But you raised an interesting point. So, and I want to go back to all of you. So, we talk about failed fundoplication. We talked about symptoms, right? Back on PPIs, what do you think about that as an indicator of failure? Just resurgence of PPI use as an indication of
Most patients don't have
failure.
reflux. At least in my experience, they just put on by, either they got
Well, we're-
admitted for something or.
This was
the
a setup
primary
based
care-
on
I
our
know.
earlier conversation. So,
So I have no idea why they get on a PPI, so no.
Yeah, if it's my patient and they got back on PPIs, I will actually wean them off, figure out where they are, and then I'll probably retest them. just to see what's going on.
Yeah, I think people do get placed on them inappropriately, and I probably would study them to make sure that they needed it. But that being said, I don't consider it a failure if they are back on PPIs. I mean, if they're fine, they're doing well, and they have a fundoplication
That's their
and
only
PPI,
issue.
and that's their only issue, I'm fine with them.
Okay.
Reg?
Well, yeah, I'm going to gently wrap up the session here because people are leaving.
Thank you.
Thank
you, Reg.
But I do have a
wanna
question.
get
How
off.
many here are non-surgeons? Okay, that's incredible. You are the true collaborators, willing to stick it out for a surgery session. Thank you very much. And I also just want to extend thanks to our speakers. And thank you guys for being willing to be the last ones in a session that's going on to 6 o'clock. So thank you. And thank you to everyone. Next year is going to be a fantastic meeting, and we're going to try to make it maybe a little less intense so that there's time.